To our research seminar. So I'm Fiona Macphail. I'm a professor in the Department of Economics here at UNBC, and I'm also the academic director of the Statistics Canada UNBC Research Data Centre. So I'm thrilled to be here and to introduce our guest speaker. Before I do that, I just want to make a few remarks. So first of all, I'd like to introduce Lorene Sluggett. Lorene is a research associate here at UNBC and also the Statistics Canada Statistical Assistant for our RDC. So if you want to know anything about the RDC, she's actually the person to talk to. But welcome, everybody. I'm so glad that you could attend today. I just want to thank a few other people. Thank you to Dr. Chelsea Pelletier for inviting her class. So we're using some of her class time. That's wonderful. I'd also like to thank Grant Gibson from the Canadian Research Data Centre Network, who's online and is organizing the webinar. So this is being it's a webinar. It's available to people across the country. I understand there's quite a few people online. And Giselle, our speaker, will now be a YouTube star after this because it will also go on the net. So thank you to Grant and to Lorene for organizing the IT part of it. I'd like to also acknowledge that we are on the traditional territory of the Kcl, and I feel I'm very appreciative and honored to be able to live and work on this unceded territory and to be able to hold the seminar here today. So I have to say a few words about the RDC. So it is a partnership between Statistics Canada and universities. There's actually 30 universities involved in this partnership through the CRDCN. And through the RDC, you're able to access detailed Statistics Canada data from surveys, census, and increasingly administrative data, which is what Giselle is going to talk about today. There's hundreds of surveys that are available, and so you'll be glad I'm not going to start reading them out to you. But there are 18 projects here at UNBC which have they're underway or they're in the stages of getting together their proposals. So we've been in operation for just over 2 years. So it's great to see so many projects, and there's so much data. So if you love data, come and talk to us at the RDC. So now it's my great pleasure to introduce Giselle Carrier. Giselle is a senior social science researcher with Statistics Canada based in Vancouver. She has an MA in experimental psychology from Simon Fraser University and a wide range of experience working with community-based women's health services, with justice statistics, and she's now working for Health Analysis Division, and she uses a broad range of survey data and administrative data. So thank you very much, Giselle, for accepting our invitation, and I'm really looking forward to your presentation.
Excellent. Thank you very much, Fiona, for that introduction, and thank you everyone for coming today. Welcome, bienvenue, and also I'd like to say thank you to all the people who are online and joined our WebEx. Thanks for coming today. It must be almost supper time in some parts of the country. And I would just like to restate for Statistics Canada, I want to acknowledge that we are on the unceded ancestral traditional territories of the people of the Kcl First Nation. I would like to acknowledge the culture, the traditional practices, and the languages spoken in this territory. Thank you for the opportunity to come here today and talk to you about linked health data, new research opportunities for health information. And I want to say, so what's up at Statistics Canada? Statistics Canada modernization, data integration is key to the future. Being responsive to a modern digital data-driven economy and society, our modernization agenda includes moving beyond our survey-first approach, using new methods of generating, collecting, and integrating data from a wide variety of sources. You might have seen our Cannabis Hub on our website. We conducted crowdsourcing using that. So wide variety of new information. User-centric, shaping, implementing our modernization agenda to be user-centric. Statistics Canada has been engaging with stakeholders, consulting with users like you guys. That's why I'm here today. We're responding by making data easier to access and use by adopting new tools to analyze and visualize data. Relevant. We live in a world where more data come from a wider variety of sources, and data are being collected and analyzed at a speed that's rapidly approaching real time. Modernization agenda means enabling Canadians to use data to make evidence-based decisions. Our government and Statistics Canada therein will position Canadians to seize the opportunities created by a data-driven world while preserving the values of privacy, fairness, and respectful use of data. Modernization agenda means enabling efficient data management and access. I'm here to talk about population health data at Statistics Canada. The program of research of health uses a comprehensive approach focusing on health determinants and outcomes across the lifespan, from birth to end of life, so that you see across the lifespan. Health determinants include the physical environment and geography, socioeconomic conditions, so those health social determinants you see on the one quadrant there, like poverty, housing, education, employment, as well as health behaviors, see on the bottom quadrant there in the circle, such as nutrition, smoking, physical activity, substance use. While health outcomes, so across on the other quadrant, that includes chronic conditions such as mental health, mortality, morbidity, and hospitalization. Equity. When appropriate, a diversity lens is also incorporated to examine health differences and health inequalities by population characteristics, such as disability, gender, immigrant status, as well as a focus perhaps on vulnerable populations, including children and youth, aging population, those living in poverty. Social Data Linkage Environment, the SDLE. It's a linkage platform at Statistics Canada. This is a secure virtual linkage environment that stores only personal identifiers. The SDLE is not a large integrated database of survey information about individuals. Linkage projects are conducted for the purpose of creating social statistics. We're not in the business of conducting surveillance of individuals. Okay, so we're creating social statistics. This involves a strong governance structure, adherence to policy and privacy requirements. There is a directive on microdata linkage. This ensures secure, approved, appropriate use of linked, anonymized, person-level data, including who has access and for how long, for intended uses as described in the original record linkage request that was approved, that showed that the data were needed and is required because the data don't exist already. So we're looking to fill those information gaps, creating new sources of linked data. In keeping with our modernization agenda, user-centric, the SDLE also provides a suite of services, tools, and supports for analysts like yourself and external researchers. Now, there's some research questions, data gap challenges, and we're going to show how linked data address these. Policy issues are often complex and they require comprehensive data to address them. In Canada, there's several previously existing challenges and persistent important data gaps. Surprisingly, data not available for analysis. So this is where linked data can help and provide enhanced data to address questions such as these and provide new information. So for example, questions like, are there differences to life expectancy according to income or educational attainment in the population for Canada? Do these patterns change across time? Were there disparities to life expectancy between population groups? Did these things change the same way or differently depending on which group you were in? Are there differences to life expectancy between Indigenous and non-Indigenous population groups in Canada? And did that change over time? Are there associations between environmental exposure and health outcomes like cancer incidence or non-accidental mortality risk? Does smoking behavior increase hospital use? And if it does, compared to non-smokers, by how much? Is nutritional risk associated with increased risk of acute care hospitalization or death? What socioeconomic characteristics are associated with opioid poisoning hospitalizations? So these are some examples, and I'm going to do some demonstrations with our linked data today to go further in this to show how linked data can help address some of these questions. Now I'm going to talk to you about one of our programs of linked health data, the Canadian Census Health and Environment Cohorts, the Cancex. These are sets of cohorts collectively known, as I said, as the Cancex. What are the 'Cancex cohorts are large population-based linked data sets that allow for the examination of health outcomes, such as mortality by census characteristics. So for example, by ethnocultural and socioeconomic factors like educational attainment. An important step in monitoring progress towards reducing or eliminating inequalities in health in our population is to determine the distribution of various health outcomes, like those you see on the screen to the right, across various groups defined by census characteristics, for example, education, occupation, ethnicity, visible minority. The idea here is that the Cancex cohorts are each created from several different data sources, but they're all created in a standardized way, so that population results for different points in time can be comparable. These analytical files, the Cancex, are created by linking long-form census respondents in the 1991, 1996, 2001, 2006 censuses, and the 2011 National Household Survey, the NHS, linked to the Canadian Vital Statistics deaths data, mortality, hospital data, the Canadian Cancer Registry, as well as the historical T1 personal income tax file and the T1 family file. Now I'll make a note, the tax files are used to obtain place of residence, usual place of residence only. So for example, postal code. For the purposes of conducting linkages, record linkages, the revenue information is not used. Why the Cancex? Typically, National Health Administrative data, like the Canadian Mortality Database, lack socioeconomic and ethnocultural identifiers beyond basic demographic information. So cause of death is there, person's sex and age, but nothing about educational attainment, for example. Whereas census long-form data contain detailed socioeconomic, ethnocultural information for each individual who provided this in their census long-form responses. But the census doesn't ask anything about health. So when we put them together, person-level record linkage addresses the absence of socioeconomic and ethnocultural identifiers on administrative data. Before these linkages, it had been difficult to ascertain the distribution of some of those health outcomes, like mortality or cancer, across groups identified by income, education, Indigenous identity, immigration. So record linkage is filling some data gaps here, some data needs. Some of the benefits of the Cancex program include this provides a rich source by which to analyze, for example, mortality of Canadians over time across different cohorts, because the cohorts is standardized in how they're produced. This provides a standardized approach to examine outcomes like longevity in different population groups. As well, we're using already existing data, those hospital data, mortality, those already are routinely collected. So we're not going out and surveying anyone to get it. So it reduces that respondent burden. The research results from these cohorts provide inputs to some of the micro-simulation programs at Statistics Canada. We do population modeling of, for example, cancer incidence in the population using published data. Because of their large sample size, the Cancex, geographic coverage and residential history of cohort members from those tax files, these cohorts are excellent tools for environmental health research. So with the inclusion of historical postal codes, estimated primarily from mailing addresses on tax returns, environmental data can be attached to these data in order to examine association between environmental exposures and health outcomes. I'm going to show you a couple of those examples today too. So one of the objectives to the program, though, also did include making the census cohorts available to external researchers accessing data. So here in the Research Data Center is one place where these can be accessed. So on to those Cancex cohorts, some information. There are currently 5 cohorts that are in use, from the 1991 census throughout to the 2011 NHS. The 2016 cohort is in the works, but won't be available to all users until sufficient years of mortality become available. So we've got some mortality data up to 2017 has been released, so certainly to 2016 has been used for the Cancex cohorts. Now to keep in mind when you're conducting research with these, the target population, so this is non-institutional, so it's household population. That means, for example, incarcerated persons or long-term care facility residents, they're not in scope for the long-form census, for the Cancex, I should say. The long form is a 20% sample of the census enumerated long form responders. 20%, but these are large population data sets. So here you get an idea of the millions. And so these are the person level records, and remember there's estimation to estimate the Canadian population from these. So these are large samples. Another thing to be aware of is the different Cancex cohorts contain different in-scope ages. So this is, you need to think about if you're designing research that is using more than one of the cohorts for comparisons, that they have different in-scope ages. There's user guide documentation provided on our website. It's available from the RDC links, and also information from our website about each of the census cycles, the particularities to the census collection. That's there as a support to researchers. Mailing address postal codes from historical T1 personal income tax files. Again, we're not using the income information, it's the postal codes. For most cohorts, postal codes are available for all cohort members. The exception is 2006 cohort. Only those who gave permission to Statistics Canada to use income info from their tax file, 2005 tax file, so the year before, who gave permission for us to use for linkage. Those are attached to their records, about 64% of the cohort members. So there you can see the different ranges of data that are available from the postal codes by cohort. So here's some of the linkages that have been done for the Cancex, starting with the mortality. The Canadian Vital Statistics Death Database contains anonymized person-level information about cause of death, date of death. And you can see there the different age, years, reference periods that are available by cohort. The other linkage that was done to the Canadian Cancer Registry. Annually, we receive cancer records from every provincial territorial registrar. And these are combined to create the National Canadian Cancer Registry at Statistics Canada. This contains information about the site of a cancer tumor, its tumor behavior, like was it malignant or in situ, the stage of the cancer at the time of diagnosis, the date of the cancer diagnosis. These come from pathology reports that are reported to every cancer registry provincially or territorially. As well, there's been linkage to the discharge abstract database known as the hospital data, links to respective cohorts. If you've used these, you'll know, but I want to say explicitly, the DAD does not include information from Quebec. So they're not in scope with the discharge abstract database. They report in Quebec to the MEDECO. So we have all other provinces and territories in the DAD. So these are the years that have been linked to the Cancex cohort. And I want to point out as well, previously people may have been using the 2006 census that had been linked to the DAD. And so this now has been taken and developed as a Cancex cohort. It's not been replaced because those other data are still available in the Research Data Center. But now we have the 2006 census that has been processed and linked in the same standardized way as the other Cancex cohorts. It's been available here in the RDC since the summer of this year. Furthermore, with hospital data, there's the National Ambulatory Care Reporting System, Knackers. So these are outpatient facility data. They're available. Again, there's some variation according to who's reporting to the Knackers by year, by jurisdiction. There's information available from the Canadian Institute for Health Information to guide us. You can produce a template on what years, what provinces began reporting. It started in 2002 in Ontario, and there's been uptake across the years by different jurisdictions. So there's a lot to learn about this data source if you're using it, but there's supporting documentation provided and available. The Canadian Institute for Information is the data holder for hospital data. Annually, they share these with Statistics Canada, and we use them for these kinds of linkages that I've just described for the Cancex. Important features to keep in mind when using or planning to use these. It's a household population. It does include on-reserve people because it's the long-form census. So different than the survey-based data that didn't include people who live on reserves, Cancex does include respondents from the Indian reservations in Canada and Indian settlements. As well, cohort weights are provided and they're recommended for use. The cohort weights adjust for record linkage effects. The linked sample represents the Canadian population, so it's recommended that you use the provided final estimate weights. And as well, there's bootstrap weights, those replicate bootstrap weights. These are produced for researchers to create appropriate standard error estimation and for estimating and calculate confidence intervals to those estimates. So those are some of the tools that are provided. Users create their own analytical cohort file using the keys that are provided by Statistics Canada. And so I've worked with these, and the way it goes is on the census, you will have that person, uniquely identifying person identifier, like a PPID, what the variable is called, and that will have attached to it another piece of information that is used as a key to link to a separate set of keys that are the linkage keys to, for example, the cancer registry that will have the person identifier. So you do that kind of match merging or SQL link, you link it, and then you're creating the crosswalk over to the cancer record. These are all anonymized, of course. And so now you have that cancer record appended. And likewise, there's a crosswalk linkage key for the dad, separate key for the dad, has that PPID, you link it person level for that. That linkage key contains the information that uniquely identifies a given hospital record. It's the crosswalk to the discharge abstract database or to the National Ambulatory Care Record system, reporting system. So you have these different sets of keys that you use in combination to make those crosswalks to create a person level file with all the information appended for your analysis. Create that analytical file. Strengths of the Cancex, that consistent linkage methodology. So if you're using different cohorts, they're produced likewise. You can create trend information. They're separate cohorts, but like they're produced this way, so you can conduct trend analysis. They're linked at an individual level. So before record linkage, we did those geographic area-based kinds of analyses, but now we have the person level records. You can examine trends over time. As well, there's a follow-up extended periodically. So as we have new data coming in, these are linked as well to the Cancex. We increase the longitudinal follow-up period. New outcomes can be added. We have some environmental data that has been added to the census cohorts. Now we're going to get into the demonstrations. How have the Cancex been used? Some examples to show some of these. So think back to that list of questions that we had about, for example, are there variations by mortality according to, so this is one of the outcomes we're going to talk about is the mortality. So I have some colleagues in Health Analysis Division, and they had some external collaborators too. They've got a paper in press right now, but they were looking at differences to mortality according to income or educational attainment. These are my colleagues for the population of Canada, and specifically, do these patterns change over time? Are there disparities to mortality between population groups that increased? The challenge is estimating life expectancy according to income or education was not feasible because death registrations don't usually collect this information. Socioeconomic disparities are known to exist from other types of studies that have been done through varied methodologies. Data sources made it difficult, though, to ascertain changes over time in Canada because things weren't standardized to draw those comparisons. So here what was done, this is another study that looked at life and health expectancies using a standardized approach. The 1996 and 2011 Census Health and Environment cohorts, the Cancex, with 5 years of mortality follow-up added, were used to estimate life expectancy and health-adjusted life expectancy of the household population to evaluate differences according to individual level income and educational attainment between different cohorts. They were looking at ages 25 to 65. So this is a study that will be coming out very shortly in health reports. We'll talk about health reports too at the end of the presentation. So you'll be able to see that published information very soon. Another example, how have the Cancex been used? These are some more colleagues. This was looking at First Nations Métis Inuit life health expectancy. So the objective here was to estimate life expectancy according to First Nations Métis Inuit self-identification on the long-form census relative to non-Indigenous persons. They examined trends to longevity since 1996 to evaluate whether disparities have changed over time in different, according to different census identities. Linkages were done for the 2006-2011 Cancex in the Statistics Canada's SDLE, that internal linkage data platform at Statistics Canada. Before these linkages, it had been difficult to ascertain the national distribution of health outcomes in a standardized way for First Nations, Métis, and Inuit. So record linkage has been filling data needs and fills this data gap with some new information. Okay, now onto some published studies. We can look at the results. We're going to look at, this is going to be using the information based on respondents to the 2001 census long form linked. This is using the environmental data to look for associations between fine particulate matter and mortality. The background here, so these are my colleagues that did this, Lauren Pinault and Dr. Weichenschall and Dan Kraus and others. Large cohort studies have been used to characterize associations between long-term exposure to fine particulate matter, air pollution, with non-accidental and cause-specific mortality. However, there's no consensus as to the shape of associations between the concentration of that particulate matter and the response. So that's what they were investigating. So they applied new annual particulate matter concentration estimates that were based on remote sensing and ground measurements for Canada with a 1 kilometer spatial scale across 1998 to 2011. They followed 2.4 million respondents who were non-immigrants, aged 25 to 90 years old, that did not reside in the institutional facility. So again, the household population. They followed them over a 10-year period for mortality. And they used the linked income tax files to account for residential mobility among respondents using postal codes, because that's relevant to exposures when you're looking at that. So after adjusting for age, sex, population center size, air shed, that's an atmospheric spatial unit of measurement, individual and ecological socioeconomic characteristics, they found that an increase in particulate matter was associated with an increase in non-accidental mortality risk. There's the hazard ratio that they reported. So this was published in 2017 in Environmental Research. They used a standard Cchs proportional hazard model to do that. Okay, another example of how the Cancex have been used. This is a study measuring associations between melanoma risk and ultraviolet radiation exposure. So the background here is the depletion of the ozone layer has meant that the ambient ultraviolet radiation has increased in recent decades. And at the same time, the incidence of skin cancers, including particularly melanoma, has also increased. The relatively few large-scale studies that linked ambient ultraviolet radiation associations to melanoma did find trend towards rising incidence closer to the equator, where ultraviolet radiation exposure is highest. Similar research had not been conducted in Canada, where ambient UV radiation is generally lower than in other countries further south. So was this a risk for us? The data and methods here, they used modeled ultraviolet radiation data for the months of June through August, from 1980 to 1990, with spatially linked geographic information systems, GIS, to 2.4 million white members of the 1991 Census Health and Environment cohort, and tracked them for melanoma diagnosis over an 18-year period, so from 1992 to 2009. They used a standard Cchs proportional hazards model to estimate melanoma risk associated with increased ambient ultraviolet radiation exposure assigned by residents at baseline. So these were models that were adjusted for age, sex, outdoor occupation, and selected socioeconomic characteristics information. So you see here the results after adjusting for all of those things. They found an increased risk of melanoma diagnosis among the white population. There's the hazard ratios on the screen. So they found this increased risk, even in a country where most people live in a long, narrow longitudinal belt. So most of us live closer to the most southern part of Canada, touching the US border. So they still found this increased risk associated with ultraviolet radiation exposure, ambient UVR. A stronger association was found between melanoma and ambient UVR among men and among people of lower socioeconomic status. So I probably want some future research to follow up on. Some other examples of how the Cancex have been used. This was a study that I was involved in. We were looking at opioid poisoning hospitalizations in the DAD linked to the 2011 National Household Survey. This study was done because although much information had been compiled by coroner's services and with the Canadian Institute for Health Information, there was national information provided about basic demographics, the age and sex distributions, the geography of where these people resided or where the deaths occurred. There wasn't much known about the other social and economic circumstances around individuals who experience these adverse events. So we were going to use linked data to try and fill some information gaps. So this uses comprehensive socioeconomic information and hospital data to try and better understand the characteristics of people with opioid poisoning hospitalizations, and to report these characteristics, like profile it nationally, so we're not just looking at a small area. Keeping in mind the limitations, the National Household Survey includes in scope, so this is private household population. So again, non-household populations are out of scope, so institutionalized, incarcerated. So some populations of interest are not included in this study, as well as residents of other collective dwellings. So people of collective dwellings weren't given a long form on the National Household Survey. That's different than previous cycles of the census, and that's important to keep in mind if you're using the Cancex cohorts that is described. For this study, we used the preliminary version of the NHS linked to the discharge abstract database. So this wasn't the official Cancex cohort that we used for this study. But now that 2011 NHS is in the Research Data Center with those linkages to the mortality database, to the cancer registry, and to the discharge abstract database. So just always keep in mind there's that difference to the previous cycles of the census, that the collective dwellings were not in scope. So with this study, using that mortality data, I compiled 6 years of hospital data. We used the protocol identified by the Canadian Institute for Health Information to identify what is an opioid poisoning hospitalization. We followed their protocol to flag those, and then compiled 6 years of data, so from 2011 through to 2016-17. And as well, the link to the Canadian Vital Statistics database was used to censor the denominator, because of course, over 6 years, you have that same base cohort population, the NHS. So they're there in that first year, the hospitalizations occur, but along the way, over 6 years, some of those people may be deceased, and they're no longer really in the database denominator anymore. So we used that to censor the denominator in calculating age standardized opioid poisoning hospitalizations. So here are some findings that this was published on October 17th in Health Reports. What we found was age standardized rates of hospitalization due to opioid poisonings were 4 times higher among those in lowest household income quintile. And another findings, we looked across a wide range of the census characteristics. So these hospitalizations were 3 times higher among parents and children in lone parent households compared to those who were married or who had a common law partner with or without children. So some suggesting at-risk characteristics. We did some other ones like housing affordability. There's some really interesting census characteristics that are useful for this kind of research. So there's considerations that I mentioned. Be aware of population exclusions and some differences to the NHS. There's some under age 1 mortality bias for the Cancex cohorts that happens when there's deceased infants, and then the mortality registry may not be linked as well to those individuals. There's changes over time in census variables, so the concepts change. So Indigenous identity is one of them. So in 2001, that was Aboriginal ancestry in previous years. So the concepts can change over time. You have to be aware of that and consult the user documentation. And as well, remember, there's no information on health behaviors. So that information about smoking behavior or physical activity, that's not on the census, and that's not in the hospital data either. That's on our survey data, and those data have been linked separately. Okay, I'm just going to check in on the time here. Okay. Should have said we'll take questions at the end of the presentation, please. And also, we're not taking questions through the mic, so, well, for the people in the room, we will when it's question time. But in the meantime, people can also tap in and put some questions through the chat box. And Lorene over here is kindly managing the people in the chat box. So we're watching that too. Okay, so I'm going to speak about, this is another one of our programs of linked population health data, the Canadian Community Health Survey, CCHS, linked to hospital mortality and historical postal code files, again, to conduct the linkage, facilitate linkage. What are the Canadian Community Health Survey? If you haven't used it and don't know, these are nationally representative cross-sectional sample survey, household population, non-institutional then, linked to different health outcomes. We've linked it, so the survey didn't. We've done it here. This creates a kind of it's a cross-sectional sample But through linkage, it creates a kind of longitudinal aspect because now we have a follow-up period with those health outcomes you see, like hospitalization, mortality, from the linkage. So the mandate of the CCHS is to produce timely cross-sectional estimates on health determinants, population, and use of health system at the intra-provincial level, so for provincial level reporting, as well as health regions. So the estimates are reliable at the regional, smaller levels of geography. That was the purpose of the CCHS. It relies on a large sample of respondents and is designed to produce reliable estimates at the health region every 2 years. That's how it was originally conceived and run. So we'll go through the CCHS. So health determinant behaviors, so there's those ones you see on the screen. There's body mass index, for example, smoking behaviors. And the linked data, I won't go into too much detail here, but hospitalization, we talked about the DAD, the Discharge Abstract Database, and there's the reference periods that are available to the CCHS that's been linked, the Knackers, as well as the Ontario Mental Health Reporting System. This is specific to Ontario. At some point, the mental health hospitalizations were being diverted to a separate capture system. So decreasing appearance after 2005, no longer going to the DAD, appearing in the Ontario Mental Health Reporting System. And the contents of that system are a little bit different too. There's some more psychiatric information, some diagnostic psychiatric tools captured in there. It's adult information, patient information, so it's a little bit different. Again, if you're a user of these data, there's documentation provided to help you. The Canadian Mortality Database described, so vital statistics for those years depicted 2000, 2017. So cause of death, date of death, cause of death, you can break it down, date of death. Record linkage offers expansive possibilities to study these sorts of process at all ages, from ages 12 and older, much more. So a different group again, because the census had infants in it. This is 12 and up. But the impact of a broad range of social determinants of health, such as socioeconomic status, ethnicity, risk factors, and disease states are reported. And here I have a whole bunch, too much information about the different hospital sources. We can come back to this screen after if people want to. So why are we linking the CCHS to mortality and to hospital records? So similar to what was talked about with the Cancex cohorts, nationally representative sample, information about all the health behaviors, health status, socioeconomic characteristics, but there's no information about death, that outcome. And on the other hand, hospital data has diagnostic and intervention information, so surgeries for inpatient visits. And mortality has information about timing and cause of death. We don't know anything about whether or not people were smokers or physically active. So none of those other important health determinants are on those administrative data. So this is addressed through record linkage. So putting them together, now we get that broad range of social determinants together with the outcomes. Here's a depiction of the different cycles of the CCHS. So it started in 2000-2001, cycle 1.1. And first it was a biannual survey that had a second focus survey in between. So 2002 had the 1.2, that's the nomenclature. So 1.1 was the first, 1.2 is the focus, and that was the mental health and well-being. You can see then there was cycle 2.1, so the general health survey. 2.2 was the focus, it was on nutrition, and thereon. At 2005-2007, there was a break from the annual reporting. It became a biannual survey instead of being a biannual survey, an annual survey that with a half-size sample. So there was a change made to that, a revision to the collection methods. I put in here some of the sample. You can see these are quite large samples. As well, for the purpose of conducting linkage, we asked respondents whether or not we could use their care card to conduct linkage and to ask for their consent. 80% of respondents consented to having Statistics Canada link their survey responses to other health information like the Discharge Abstract Database or to the mortality data. Linkage weights are available to ensure that the linked sample is still representative of the overall population. So again, recommended that you use the provided linked sample weights. When you use the CCHS, sometimes what we've done is we've created a pool, because your health outcome might be scarce, a scarce event. You can create compilations of a couple of different cycles of the CCHS, pool it together, try that strategy. It's important to remember, though, that across the different cycles, there can be changes to the collection mode. So some of them may have been in-person interviews. The sampling frame may have been changed a little bit. The target population, like the ages that are in scope, might also be different across different cycles of the CCHS. So again, it's very important to consult the user documentation to learn about the details of the data source. So here's some, I'm going to go through these slides quickly so we can get some more of those cool examples. So here we've got the CCHS linked to the DAD. And you can see the DAD we have available from 1999 thereon. The CCHS, the inaugural year was 2000, and they're for the different focus surveys. So there's good coverage overlap. And same for the Knackers, that outpatient care, but that's got ED department, outpatient surgery, so day surgeries, that would be in there. And again, the reference periods are good for use with the CCHS that have been linked. The OMERS, the Ontario Mental Health Reporting System, same thing. Same with the Canadian Vital Statistics databases. So the deaths, we've got coverage there from the beginning of the CCHS. They're on to 2017 has been linked to the CCHS. We've used the historical postal code files to conduct the linkage. So we are taking care of those movements of people across time to account for that when we link to the mortality database. Now, some examples of how the CCHS and mortality and DAD have been used. So again, remember those characteristics are in the survey data. And even though the hospital mortality data contain age and sex, we focus on, you've got to think of the base universe. That's your universe you're using. That's the survey that you're thinking of as your study population. And then use the outcome as in the linked data source. So these are my colleagues, Pamela and Heather. They looked at nutritional risk, hospitalization, and mortality across community dwelling Canadians aged 65 and older. And why did they do that? Other information showed that just over a third of seniors were at nutritional risk. So that was from probably the nutrition survey provided that estimate. And it's known that negative health outcomes are associated with nutritional risk, functional limitation, declines in quality of life, longer hospital stays, ultimately death. Previous studies investigated nutritional risk and these outcomes, but they were small, non-representative samples. So need to know and need to conduct record linkage. The request was made, approved by the Chief Statistician and the Executive Management Board of Statistics Canada. And this study was done with these linked data. So they were asking, is this associated with increased risk of acute care hospitalization or death? Here's what they found. After adjusting for those other demographic, health status, smoking, other those health determinants, they found this was the hazard ratio for hospitalization, so increased risk, and same for death. Another example, how have the linked CCHS to DAD been used? Here looking at excess hospital days for smokers. Catherine Wilkins, Margot Shields, and Michelle Radman are my colleagues in Health Analysis Division. And their question at hand was how did the likelihood of hospitalization in acute care hospitals differ over the next 4 years according to smoking status? And notice they've said specifically acute care. The reason why we use the acute care, we tend to use, and CHI, the Canadian Institute for Health Information would recommend that as well, is there's comprehensive coverage of acute care facilities in the DAD. So like 100% of the acute care facilities are recorded in the DAD. The other kinds of hospitalizations like chronic care, rehabilitation, there are some of those hospitalizations in the DAD, but it's not 100% coverage. So if there's any bias, it's not, you don't know about it. And it's acute care, you're good. So here's what they found. You can see the association. There's this gradient, and the stars mean it was statistically significant. Reference group being the never smokers. It was prospective, so they looked at the 4 years before, 4 years later at the smoking, from smoking reported on the CCHS at the hospital use. And what did that mean? The estimated excess day for smokers account for nearly 1/3 of hospital days used by people these ages. Excess day for smokers compared to, and former smokers compared to non-smokers amounted to 7.1 million days in acute care hospitals. associated costs. So a lot. So considerations when using these CCHS linked data, think of the population not in scope. So those living in institutions, those living on Indian reserves and settlements. Quebec's not in the DAD. It is in the mortality data, but not in the hospital discharge of the Knackers. It's a cross-sectional survey, so it's not in itself longitudinal, but through linkage, you create a longitudinal aspect using the CCHS as the base cohort. Survey collection redesigns that occurred in 2007 and 2015 to the CCHS, changes to sample frame, the target age, the core content, because some of your favorite variables, whether it's alcohol consumption, it may vary across the different cycles. You need to find out from the documentation. The respondent information is available at the baseline only. So obviously, if you're linking to hospital data 4 years later, you don't know if they're still smoking or if they become less active. Those changes to their behaviors, you don't know because you just have that initial input from the CCHS. And the sample size of the linked outcome, you have to think about what it is you're trying to measure. Some events like, for example, opioid poisoning hospitalizations are small counts. They can be small counts. Pooling information can help address this, but something to consider in the design. We have a lot of linked health data available at Statistics Canada. Some other examples here. My colleague Tracy Bushnick was involved with the creation of the Canadian birth census cohort. So again, it's a standardized cohort from using 1996 census and 2006. These use the registry information on birth statistics that we have at Statistics Canada, vital statistics. As well, you've got the cancer registry linked to these other files here, the CVSD tax file, again, probably to control for that mobility of patients. We've got the CCHS linked to the longitudinal immigration database, vital statistics to the National Ambulatory Care Reporting System, immigration database linked to the discharge abstract database. Can look at hospital outcomes for immigrants to Canada, can look at since the time they landed or under the category, the immigrant status. So were they a non-permanent resident, or were they an economic category landed immigrant? There's different categories for the landed immigrants you can look at. Where are the Cancex and the linked CCHS data? They're here in the Research Data Center. Here with Lorene managing the center. And you can see on our website, that link at the bottom of the screen, you can see the Research Data Center has a link. There's a lot of different items in there you can navigate and find from. And in there, you'll see the data that are available. This gets updated as the data are placed in the Research Data Centers across Canada. So you can see what is in there and what's not in there. As well, you can see who's using the CCHS, the linked data, the Cancex, the RDC projects, all the RDC projects, the users of them are listed. We're transparent at Statistics Canada about record linkage, what databases have been linked, as well as what projects are being used to, are using these person level data in the research data centers. These have been approved for use. And this is updated quarterly, so this gets refreshed from time to time. And if there are questions here for the University of Northern British Columbia, you can direct those to Lorene Sliggett, who's kindly helped hosting today's event. And she's at this address, as well as I've put on there the website for the Research Data Center. And I just want to say thank you very much for your attention. And also on here, that's the address for the Health Analysis Division. That's where I work. I telework from the Vancouver Regional Office for Ottawa. So I access microdata in Ottawa through remote server connection. And so we were going to take questions if there are some. I just want to say before I turn that over to there's some other materials I put on the chair. There's like copies of health reports or some information about health reports. That's our peer-reviewed scholarly journal. That's Medexed. And so it's Medline linked, so you can access information from health reports. It's downloadable for free in both official languages. And if you want to leave me your name or send us your name, you can put on an advanced notification list to get pinged when there's a new health reports coming out. So these routinely come out from Health Analysis Division. All right. So did you want to say something before we take the question? Thank you.
So if there's any questions online, feel free to just use the question chat box as well.
Is there an equivalent database like OVERS for BC?
No, this is Ontario data, just Ontario data. For BC, the mental health hospitalizations, so the equivalent of that would be the diagnostic fields in the DAD for BC. So those will be inpatient, so acute care hospitalizations. You can look at the diagnostic codes. Those are classified according to international classification systems. So the ICD-10 version 10 are in the discharge abstract database. So you can, yeah, right. So you can find like the codes that exist to define mental health. And when there's information, both at the Canadian Institute for Health Information, but from our own publications from time to time, we have it in an appendix. We had a publication on mental health hospitalizations among First Nations in Canada. So in there we had in the appendix, for example, the ICD-10 codes that are included for the different mental health behavior diagnosis.
And you can do other patients that are going towards the medical services.
Yeah, sure.
I just, one of my observations is that a lot of people don't go to the RDC because it's like a process, right? It feels like it's going to be difficult. So I just wondered if either of you were willing to talk about how, like what process would a student go through if they wanted to access their research? Maybe for these kids.
Do you want me to talk about that, or do you want to talk about this?
I guess sort of from broad stroke, on our website, there is actually information if you search by RDC or look for the RDC link, there is in there information about how to apply to gain access, because there is a process, because it's secure information. And the process there, it lays out exactly what you need to do step by step. And so that information is reviewed by the Research Data Center Management, and then that's how people gain access.
Mm-hmm. Yeah, so yeah, that pretty much summarized it. Yeah, I mean, yeah, we always encourage everyone to come. You can make an appointment with me anytime. So even if you're at the very beginning of you don't even know what you want to research yet, you can come talk to me, because there's so many data sets. It can be challenging to go through all of them to figure out what might apply to your research. So we encourage people to come talk to me first, and then I can help guide you. There's a proposal that you write, and it's maximum 10 pages long, and then there's a security screening process. And the whole process for students is quite a bit shorter. It can go through in about 2 weeks. Right now it's going through in 2 weeks anyways. For faculty, it's more like 8 weeks. So yeah, get your proposals in early.
Yes, I think that's the first thing to do is when you think of a question that you're interested in, then the first step would be to try and see your needs, so that you could talk about what data sets are available that you might use to answer your question. And there's documentation on all of those data sets, so you can go through and see what variables are there and match concepts in your query. So that would be the first stage. And then just, figuring out it's all on the website, and we will walk you through it as well. It's all laid out on what the steps are. From time to time, we also have workshops to help people, figure out how they go from the idea to the concept to the.
Yeah.
I have a question about the so I've used the human health measures again, and does that link with is the survey linkable with the census or with the?
It may be linkable data. I'm not aware of any linkages done with it, which doesn't mean it hasn't been done. Because this is not comprehensive of all linked data at Statistics Canada and the RDC. The website of the RDC will show what data are available presently in the Research Data Center. So here, this. So from Statistics Canada website, from the Research Data Center, there is a click data available. You can see on the left side of the screen, data available. And in there you can navigate and find all the different sources by search term. or you can ask Lorene if she knows. Yeah, I think the health measures survey is not one of the linked data sets that's in the research. I haven't heard of a linkage being done. Just, like I said, doesn't mean it hasn't.
Like I remember at this discussion, just because this has like tons of interesting physiological information, barely no health information. So definitely like linkage, I'm like, oh, that would be great.
Yeah, and the way linkages happen at Statistics Canada, so it comes back down to that, the need to know. So there's an important research question. There's no existing data that can answer the question, so that is shown if you show that. Because if other existing data exists, there won't be a record linkage done or redone. And when the need to know is expressed and shown how it could be done, and it looks feasible that it could be done with those data and hasn't been done, a record linkage request can be made to Statistics Canada to the social data linkage environment to explore that, the feasibility of that and what would be involved. There might be a service cost recovery with that, I'm not sure, but it's feasible. Eventually, when things are requested and there's the need and all those things I just said happen, then it goes through the Executive Management Board of Statistics Canada for approval. They consider all the information because they weigh it against the record linkages in some ways invasive of privacy, so they consider that versus the greater good. And as well, because it's protected through the process of record linkage and for subsequent use, even by staff. You know, we don't see person information. We see person level, but it's anonymized. Even the record linkage, they only get pieces of it while they're doing the linkage. They don't see everything all together. Then the Chief Statistician, even of Canada, approves each record linkage request. It's taken seriously, and then the linkage is done. So I hope that helps. And come back again if you still have some need for help that's going forward, not addressed, and you want help. I'm kind of representing Ottawa being here today, so that's what I'm here for. And I think this is a conversation that can continue after the presentation. We're going to still be around for a while. And even if you want to talk one-on-one with me about your project or something, I'm here. And also, even after today, feel free to reach me at my email address even. And I think I'll go back to the start of the presentation because it has my name. Because in the federal government, the email address is firstname.lastname@canada.ca. It will be how you find me. But don't put my accent grave on my name. It will goof it up. That's how you spell my name. But just put Giselle.carrier@Canada.ca. There's my name. So Giselle.carrier without the French accents @Canada.ca. If there's anything else that comes to you after today.
Sorry, Giselle, there's a question from the online participants, if you wouldn't mind.
Yes.
The question is, can different cycles of CanCheck be combined for some population subgroups, say, for example, Inuit or First Nations?
Can they be combined, like to be a bigger cohort?
Yeah.
Yes, I think that would be possible because, again, they're collected in a standardized way. You have to pay attention to the ages that are used in the study, like what's being analyzed, to make sure those things line up. Because as said, some of the different cohorts have different ages in scope, and as well paying attention to the identifying concepts. So, you know, in 1991 there was Aboriginal ancestry, and then later on it was Aboriginal identity. So the concepts were different. So just paying attention to the differences in the cohort in those kinds of regards, for example, then yeah, I think that could be done.
Another question?
This is not a question, but just a segment. The Department of Mathematics and Statistics in the January semester is going to be offering a course called Survey Sampling Design and Analysis. You'll be able to enroll in it as an undergraduate if you want, as Stat 472. If you want to enroll in the course as a graduate student, it would be Stat 672. It'll be offered Tuesdays between 2:30 to 5:30 in an integrated classroom laboratory environment.
Excellent, thanks for announcing that. I guess I should also say then, because I just want everyone to be aware that Health Analysis Division does seminar series So every month there is a presentation, a WebEx presentation. It's for free. Anyone can come watch. And so for your seminar course, that's something that students could attend. Anyone can attend.
So how would we find out about those seminars?
Huh. So from the Health Analysis Division, from the link, I gotta go to the bottom of the presentation again. You can email Health Analysis Division and let us know that you'd like to be notified when there is a seminar series presentation happening. We have a communications manager in Health Analysis Division, and so she can get in touch. She keeps the list of people who want to be part of the pre-announcement for the health reports as well. So we can let you know that this seminar series date and what the subject is before the presentation, so you can decide if you're interested or not to come. So that's our email address, Health Analysis Division. There you go.
Grant, I just want to say I can't see the questions on my panel, so for some reason they're not coming up. So if you have
Okay,
more,
well, that was the only one so far. So
okay.
Casey had his hand raised, so I don't know if he wants to type his question into the chat, but that might have been an accident. Sometimes happens.
Okay. Do you have a question? Or did you have your hand up? No? Oh, okay. Questions?
Well, thanks very much, Giselle. Giselle, one more question for us.
Thanks for the opportunity to present information to you guys. Thanks for coming today.
So I'll just add one more thing to everybody before you guys go. I did put out, there's an email list that I know some of you are already on, but if you're interested in keeping up to date with what's happening at the UNBC Research Data Center, you can sign up for the e-list. I send out a message usually about once a month, just about new data sets or events that we're doing, seminars, this kind of thing. So you can sign up for that. And if anybody is interested in data and you just want to have a talk about the opportunities in the center, feel free to just make an appointment with me, and I'd love to talk to you and talk about your ideas and see if we can find a data set that relates to your ideas. So that would be great.
So please stay around and.
Oh, hang on. Sorry, we have one more question from the internet.
One more question.
One more question online.
Yeah. Is there a way to check for duplicate inclusions of individuals from different cycles of Cancex? So if someone was showing up in multiple long form censuses, would you know that from looking at multiple waves?
I'm gonna just say that in the Cancex program, probably they've thought about this, and it's possible that people can be long form respondents more than once that would be included in the Cancex cohort. We don't do record linkages across sources like in the research data center, right? These are the linked data that are already available. So whether or not there's a kind of dependency, I think is what you're getting at, because that can affect the estimation processes, whether or not it's an independent or dependent. So I think that's all I can say to that. And maybe I can get some more information from the manager of the Cancex program to see if they've actually found some way to identify those cases, if there are any, to flag them somehow if that's a concern.
I think it would be, and I think the answer is no, there's no way to check. I think the ID is unique for each Cancex wave.
Oh, yes, I think that is true, I think. So yeah. I think if you want to give me, I can get the name and number, the name, or you can contact me through giselle.carrier@canada.ca. I'll make sure that I find out definitively from Mike Chepkema, the manager of the Cancex program.
I think that's the best case scenario. Now we've got lots of questions. Is that okay? I know we're probably getting towards time here.
Sure.
Okay. Is there any data set that links with genetic data?
Not that I know of, no. Well, there's the, no, because the Canadian Health Measures Survey collected biological samples from people, so there's no gene in there. Okay, so we have a user of, and we already talked about that. To my knowledge, there's no linked Canadian Health Measures Survey data. So I guess no.
I think people have, I saw, there was a project once that I saw that was based on CHMS. It was looking at folate levels and how that was related to a certain genetic variant of folate. I can't remember what it was, some type of gene to do with folate metabolism. So there must be something there. It must have been maybe through the biobank possibly, which wouldn't be available to everybody, I guess. I'm not 100% sure about that, but I do know that somebody did something on it. So there must be.
Oh boy, because this is, I'm sorry, this is going to be another, we'll come back. We'll find out from the manager of the Canadian Community Health, or from the Health Surveys and Health Statistics Division. They're the Canadian Population Health Division. They've been renamed. They're colleagues of mine. So I'll find out definitively for you from that. If you contact me at giselle.carrier@canada.ca, we'll get definitively to the bottom of that for you.
And the last one that I see so far is are CCHS cycles linked to the Canadian Cancer Registry?
Wait. We linked it to the discharge abstract database and to the mortality database.
Do you know if there's plans to link to the Cancer Registry?
I don't know.
Yeah, I don't think it is either.
Yeah. Looking back to, wait a minute, I've got some information from, just looking back at some information I was given from them on their recent linkages.
I don't think it is.
Here we've got, no, it's the DAD and the Vital Statistics Database, Knackers, OMERS, and historical postal codes. So no CCHS to CCR.
Okay, now I'm out of questions. So.
Okay.
Thank you for your questions, you guys.
All right. Well, thank you so much, Giselle, for your presentation and all the questions. Everybody, thank you for coming.
And also I'd like to thank the UNBC for working with us.